hematology. Okay, we were talking about these disorders. Okay, we were covering the anemias. So let's take a look. There is a slide that is towards the end of the PowerPoint. Okay, that contains how to do a differential diagnosis. We are gonna, I simply copied and pasted that slide here. Okay, before hemostasis disorders, that is towards the end in the resources, because I wanna go there. Okay, now before jumping into hemostasis disorders. Okay, remember, when we have a patient with anemia, it is very difficult to do a differential diagnosis just based on the clinical presentation, okay, because these anemias normally present either asymptomatic or with the same signs and symptoms in every patient. Fatigue, shortness of breath, that can be on exertion or at rest if the anemia is very severe. Okay, so then or pale mucous membranes, etc. Sometimes there may be jaundice if the anemia is hemolytic. Okay, but besides that, there is not much, okay, that we can use clinically for the differential diagnosis. We can use the history of the patient, okay, but that also doesn't help too much, because imagine you have a person, a woman that has irregular menses, heavy bleeding, and you suspect, oh, this woman may have a iron deficiency anemia because of the bleeding, but maybe that's true, but having that doesn't rule out other conditions, because someone may have a hemolytic anemia, maybe autoimmune hemolytic anemia, or other type of anemia, and also have a heavy bleeding, irregular menses, and have a mixed type of anemia as a result of this combination. Okay, so let's go to these. There you have the pathophysiology. Notice that all the types of anemias are going to produce exactly the same. Okay, this is a square here that says etiologic events. Okay, there are causes of anemia that lead to decreased erythropoiesis, and also there can be blood loss, or there can be blood destruction. So all the etiologies are there. And all the manifestations and all the mechanisms apply to all the causes of anemia. Okay, so let's go to this evaluation of anemia, because this is probably the most important thing for you as students now. Okay, you have your patient with anemia. Remember, we detect that on the CBC. There may be decreased hemoglobin or decreased number of red blood cells, or both. Okay, then we have to take a look at different values that are important in the CBC. Okay, one of the first values that we look at is at the mean corpuscular volume. Okay, this talks about the size of the red blood cells. And then we look at other things, for example, the number of reticulocytes, okay, etc., to have an idea. Okay, this depending on the CBC and depending on the MCV, mean corpuscular volume, okay, we are gonna separate the etiologies of anemia into 3 groups. Okay, normal MCV, that is called normocytic. Let me write it there. Normocytic. Normocytic anemia. Then we have low MCV, okay, that is microcytic, and large MCV, more than 100, and that is going to be macrocytic. One important concept here is to remember that macrocytic simply talks about the size of the red blood cells. Okay, many, I know this is very common, consider or think that macrocytic is the same as megaloblastic. That is not correct. Okay, megaloblastic anemia is a type of macrocytic anemia. Okay, and to diagnose a megaloblastic anemia, we have to look at different things. For example, if you do a blood smear, okay, we can find what we call hypersegmented neutrophils. Oh, neutrophils, which is simply a neutrophil that has more than 4 lobes. Or we can do a bone marrow aspirate and find a specific type of cell that is called the megaloblast. The presence of megaloblastosis in the bone marrow, okay, points towards a megaloblastic anemia, because macrocytic anemias are divided into megaloblastic and non-megaloblastic, okay, depending on the findings. Okay, so let's start here. No, we are talking about macrocytic anemias. When you have this elevated MCV, you have to look, for example, at the levels of serum B12 and folate. Remember, folate, we have a store for about 4 or 5 months. So people with nutritional problems, alcoholism, or any other nutritional problem will present with folate deficiency first. Okay, then serum B12, we may have store of B12 for a year, 2 years, depending on the previous status of the patients. Okay, but we also can differentiate B12 and folate deficiency because of the clinical manifestations. For example, low B12 typically have neuropathy, neurological problems. They may have loss of vibration, loss of proprioception, loss of two-point discrimination, some numbness, tingling, or different neurologic disorders peripherally. Okay, folate deficiency, they don't have neuro manifestations. Okay, but if the cause is confusing because the neuropathy is a late finding. Okay, maybe they have low B12 and they still don't have the neurologic manifestations. So we have to look at the values of homocysteine and methyl malonate. Okay, notice that when there is a B12 deficiency, I was telling you that you can use this mnemonic. B, you can use both, because both are elevated in B12 deficiency, both elevated in B12. In folate, notice that they only have elevated homocysteine, not, okay, the methyl malonate or methyl malonic acid. Now, how will the student remember? Because I'm telling you how I did this. Okay, in medicine, we have to study in a very short time tons of things. Okay, and we have to make sure that we remember them forever. Okay, for sure, if I tell you this now, you will remember, but remember, our short-term memory is not very friendly to us. Okay, the main job of the brain regarding memory and learning is forget. What the brain will forget? Everything that we don't tell the brain to remember. So we have to guide our hippocampus, okay, to store certain information in some place. How will we remember that homocysteine is the one that is elevated in both B12 and folate deficiency? Well, at least this is what I use. Maybe it's not an excellent mnemonic, but for example, patients that have B12 and folate deficiency, both deficiencies will lead to an increased cardiovascular risk. And then I know, and you should know, that homocysteine, elevated homocysteine, is a marker for cardiovascular risk. Okay, so I associate the B12 and the folate with cardiovascular risk, and they both have elevated homocysteine, and that's the way that is organized in my long-term memory. And when we pull from one piece of information, everything else comes with that piece of information in my working memory. Okay, that's something that I recommend you to do. Okay, try to, when you study, okay, do it in a way that you are, it's like if you are organizing your house. You go shopping, you buy food, clothes, you buy many things, then you store things in places that you will later remember where they are. You don't put the shoes in the freezer, and you don't put the bread with the shoes, okay? In the same way, we have to study organizing the information in a way that then we know how to retrieve it. Okay, now, notice this here. Once we decide this patient has B12 or folate deficiency or both, someone can have both perfectly, then we have to determine the cause. Okay, this is not a diagnosis. When we say the patient has B12 deficiency, that's not the end of the story. Okay, saying that is like if someone is a policeman, a policewoman, or a detective, and they say, oh, this is murder. Yeah, okay, now what? We have to find who did that. Why they have B12 deficiency? Is it because they don't eat? Is it because they don't absorb? Or is because they have antibodies against intrinsic factor? Or they have a chronic atrophy of the stomach? Or they have a problem in the ileum, like Crohn's disease, and B12 is not absorbed? Or they have a liver disorder? Or we have to find why. Or a parasitic infection. There are many different causes. And these B12 and folate deficiency are the main causes of megaloblastic anemia. Because there are other macrocytic anemias that are non-megaloblastic. And these are here. Okay, liver disease, hypothyroidism, drugs. We should include here alcohol. Of course, excessive alcohol intake. Okay. And then we have to look at more things, because if we don't have a clear diagnosis, then probably we have to do a bone marrow aspirate, because maybe they have a myelodysplastic disorder, dysplasia in the bone marrow, bone marrow. Okay. For example, if they have the macrocytic anemia and also they have low levels of white blood cells or low levels of platelets, okay, we have to look at precursors of the leukemias. This is like a premalignant lesion. The patient may develop a leukemia in the future. Okay, that is the approach to the macrocytic anemia. Okay, now let's go to the microcytic anemia. Okay, if your patient has a microcytic anemia, notice that we start with iron studies. In the case of the macro, we look at the B12 and folate. Here we follow with iron studies, and this is something that is essential, for example, to answer questions of the type. Which of the following is the best next step in the diagnosis of the condition of this patient? That is a typical question in the PANS. And the typical vignette is patient that complains or comes because of fatigue, shortness of breath, and exertion. On physical exam, the mucous membranes are pale. Okay, which of the following? And we do a CBC. Well, if they stop there, What is the best next step in the diagnosis? That's a CBC. Okay. And if they give you the CBC and they tell you that there is a macro or microcytic anemia, then the next step is B12, folate in the case of macrocytic, and iron studies in the case of microcytic anemias. What about the normocytic? What is the best next step? Notice that they look at the peripheral smear, okay, and other things that we are gonna tell you now. Now, what do we get in the iron studies? Well, we are gonna look at the serum iron, okay, serum iron. We are gonna look at different values like the TIBC and the ferritin. And I told you this ferritin, you should associate ferritin with iron that is stored. And the TIBC, okay, is a measure of a protein that is called transferrin. Transferrin, transport of iron. The TIBC or the transferrin is a protein that transports the iron from the intestine, okay, to the places where we store it, and from here may transport it to the bone marrow. Okay, for making red blood cells. So when you measure transferrin, you measure the amount of iron that may be traveling in the blood. Ferritin is the amount of stored iron. Now, what is the meaning of TIBC? TIBC, I think you have it here, total iron binding capacity. Indirect measure of the protein transferrin. If we have a low total iron binding capacity or a high iron binding capacity, that has different meanings. We have low capacity. That means the transferrin is full. The transporter is full. High capacity. The transporter is empty. We have a lot of capacity to put iron there. And for me, the mnemonic that I used in the past, I used to take this T for taxi. Okay, there is a taxi that is looking for something, maybe empty, maybe full. If it's empty, there is a lot of capacity. If it's full, there is no capacity. Okay, now let's see how we use this to interpret. We do the iron studies. There is low iron. There is high capacity to transport iron. And there is low stored iron. Well, obviously, if there is low stored iron, the savings account is empty. There is no iron in the movement, so there is no iron anywhere. That is an iron deficiency anemia. Low serum, low stored, high capacity. There is a taxi that is empty looking for iron. Scavenger protein looking for iron, but doesn't find any. That's why it is empty, high capacity. Now, in the same way that I told you, B12 is not a diagnosis, iron deficiency anemia is not a diagnosis. It's a finding. Okay? Oh, this is not murder. This is manslaughter. No, I don't know. And then we have to look for the actual cause. Why they have iron deficiency anemia? Do they have a colon cancer? Is simply abnormal excessive bleeding? Is a chronic gastritis or a chronic ulcer and the patient is chronically bleeding? Is acute bleeding? Is dietary problem? Is that they are taking For example, lots of calcium, lots of antacids. Remember, iron needs a low pH in the stomach for absorption. It's a malabsorption problem in the intestines. It's a bacterial overgrowth that doesn't let iron to be absorbed, and these bacteria are using the iron that gets there. Now let's go to the next. The iron in the serum is low. Okay, but now they have a normal or low TIBC. Okay, and they have a normal or high ferritin. That means all the iron is stored, is not in the serum, and there is no scavenger protein. So there is no one out there looking for iron. That happens in anemia of chronic disease, infection, inflammation, or cancer. Remember, the inflammatory cytokines, when they are released, they are gonna stop the movement of iron. So all the iron that is available is gonna be placed in store, and it's not gonna be moved from any place to any place. So the bone marrow doesn't get iron to make blood cells. Because for our body, inflammation means infection. Our body doesn't know if this cytokine is here. What is the reason for that? Simply it's a signal that tells the liver, spleen, bone marrow to do different things. So our body interprets the presence of inflammatory cytokines as bacterial infection, and we are not going to let the iron to be available for bacteria, but unfortunately, it's not going to be available either for the bone marrow to make red blood cells. Okay, and then we have this part here. Patient has microcytic anemia, but they have a normal or high iron in the serum, and the TIBC ferritin may be in different values, but the important thing here is the high iron. Then we have to look at, for example, if there is iron overload, okay, in the peripheral smear. Okay, we are going to see special characteristics of the red blood cells when they have lots of iron. These are called siderocytes, or we may find what we call sideroblasts on the bone marrow, and we call that sideroblastic anemia. Why they have elevated iron? Well, there are different things. Okay, hemochromatosis, or they may have a polycythemia vera, different things that may produce increased iron. Okay, and another cause of this type of anemia with the elevated iron is what we call the thalassemias, which are inherited conditions, and we are going to recognize them because of the family history. Okay, maybe because of some skeletal abnormalities, okay, and the presence of abnormal cells in the peripheral blood smear. Okay, teardrop, target cells, they may have splenomegaly, family history. Okay, so notice the steps. CBC, look specifically at the MCV. Depending on the MCV, we do either B12 folate or iron studies. After this, we may do a bone marrow aspirate if we need, or we may do a peripheral smear, okay, depending on the findings on the serum iron studies, and even genetic studies if necessary. And then we have to continue, because if you detect, okay, this is an anemia of chronic disease, well, what is the chronic disease? Do I know, or do I have to look for it? Now, what about the normal MCV, normocytic anemias? Remember, this is the next step after we have the MCV, okay, peripheral smear. We may have different findings. Okay, for example, normocytic anemias may be due to hemolytic anemias or blood loss or bone marrow suppression or kidney insufficiency. How do we know that there is hemolysis? Well, there are going to be different markers. For example, elevated lactate dehydrogenase. This is an enzyme that is normally present in the red blood cells. Remember, red blood cells don't have mitochondria, so they only do anaerobic respiration with the production of ATP and lactate. So if there are many red blood cells broken, we expect many of these enzymes that normally are inside the red blood cell in the blood, LDH. LDH is an enzyme that is very unspecific. Okay, lactate dehydrogenase may increase also in cases of shock. Okay, for example, notice that we are doing anaerobic metabolism. So the lactate dehydrogenase is working a lot in cases of shock, any kind of tissue injury will increase the lactate dehydrogenase, and also hemolytic anemias. There is going to be an increase in bilirubin. The patients may have jaundice. There is going to be a decrease in haptoglobin, elevated bilirubin, decreased haptoglobin. What is haptoglobin? Well, this is a protein that is circulating in blood, and it normally binds hemoglobin. Okay, if red blood cells are broken, let's say you have a certain amount of haptoglobin in blood. Okay, a person who doesn't have any problem or doesn't have a hemolytic anemia, let's say have 100 units, just to say a number, of haptoglobin. If there is hemolysis, a lot of hemoglobin is going to the circulation. Free hemoglobin binds to haptoglobin. So when you do the blood test, the haptoglobin goes down, because we detect only the free haptoglobin, not the one that is bound to hemoglobin. Okay, bilirubin comes from the metabolism of hemoglobin, so the one that is not bound to haptoglobin is being broken down, forming bilirubin. Normally, when there is hemolysis, I think I need to erase this, no? Okay, when there is hemolysis, okay, the bone marrow will respond by increasing the production of red blood cells. So we may find an increase in the number of reticulocytes. Okay, that are responding to the breakdown of red blood cells. Okay, because another cause of normal MCV is bone marrow suppression that may be due to chemotherapy, infiltration by cancer cells, autoimmune attack, toxins, medications that, for example, produce what we call aplastic anemia. Aplastic, not making anything, aplastic anemia. When there is bone marrow suppression, we are going to have a low reticulocyte response. And then we have a renal insufficiency. In renal insufficiency, there are a lot of toxins. Okay, for example, uric acid, creatinine. Okay, this uric acid specifically, okay, may suppress the bone marrow. So the bone marrow exposed to these elevated levels of uric acid will stop making anything. Okay, and that's the way we do we approach the patients, okay, with anemia. I hope this helps you. Okay, this only has a lot of great information that you can use. And then we were talking about we started mentioning, okay, how we approach the bleeding patients. Just to remind you, hemostasis is divided into primary and secondary. Primary hemostasis is the one that has to do with the platelets activity. Okay, when there is a damage to the endothelial cells and collagen is exposed, platelets will first adhere and they will get activated. They are going to release different signals like serotonin, ADP, that will attract more platelets that will aggregate to those that were previously there. Say you have these platelets getting there first, and then they're going to attract more and more and more and more and more, forming a plug. That is the primary hemostasis. And then the secondary hemostasis is the one that has to do with problems in the coagulation cascade. Okay, once we have this plug, the plug has to be stabilized by fibers, and these fibers are made of fibrin, okay, and that is a clot. Okay, the activation of the coagulation cascade, intrinsic, extrinsic pathway, leads to activation of thrombin. Thrombin activates fibrinogen into fibrin. Fibrin holds all of these platelets, red blood cells, etc. together, forming a blood clot. So we are gonna approach the patient in this way. Is there a disorder of the primary or secondary hemostasis? Normally, platelet disorders have to do with decreased number or quality of the platelets, or with some inherited disorders. We are going to be seeing examples. When someone has a platelet type bleeding or a primary hemostasis disorder, they tend to bleed immediately after an injury, and typically the bleeding is superficial. Can be petechiae or can be bleeding into the mucous membranes like epistaxis or epistaxis. Bleeding gums, epistaxis, may have increased menstrual bleeding. Okay, and by a general rule, prolonged bleeding time. And that's something that is sometimes the typical complaint of the patients. When someone has a cut, a little cut, okay, maybe we bleed for some 30 seconds, maybe no more than a minute, depending on the amount of the severity of the injury. But if you have someone that is bleeding for 10 minutes, 15 minutes, 20 minutes, and then they cover it and they continue bleeding and they have to change the dressing and they're still bleeding, what's that? And every time they brush your teeth, they bleed a lot. They have lots of nosebleeds, etc. Okay, formation of petechiae with minor pressure sometimes. And the secondary hemostasis disorders, the ones that have to do with the clotting factors, typically are delayed. Let's say a kid is playing sports, they may fall or may have any kind of injury that is mild, nothing happened on, let's say, go home. And the next day they wake up with a swollen knee, swollen elbow, or some important intramuscular or intra-articular bleedings. And they have lots of large ecchymoses or bruises on the skin, or sometimes taking a huge area, or hemarthrosis. These are typically due to congenital defects, for example, hemophilia, or maybe due to vitamin K deficiency. Okay, vitamin K deficiency will affect almost every factor in the coagulation cascade. And remember, vitamin K is a vitamin that we may obtain from the diet, but one of the most important sources are the intestinal bacteria that may take many precursors of vitamin K and process it to give us the vitamin K. And the main reason why we give vitamin K to kids, okay, after birth, is that they don't have any, okay, and they're not gonna make vitamin K in a while, because they still need to develop their intestinal bacteria, and then this intestinal bacteria will start making vitamin K. And we have the interpretation of the coagulation studies, for example, PT and PTT, okay, and also the D-dimer are different tests that we use to assess how the coagulation factors are, if it's the extrinsic, the intrinsic, if this is due to a medication, okay, warfarin or heparin, or different other vitamin K deficiency, or many different things that may alter the coagulation. Okay, normally when there is a platelet type bleeding, these things are going to be normal. And there are mixed disorders, people who have disorders that affect both primary and secondary hemostasis, like Bombiligram syndrome and, okay, the DIC, disseminated intravascular coagulation. Let's start with platelet problems, thrombocytopenia. Okay, this simply means low levels of platelets. And this is a finding, okay? This is not a diagnosis. There can be many different causes. Okay, one common cause is ITP, immune thrombocytopenic purpura. This in the past was called idiopathic thrombocytopenic purpura, so it was a ITP, but this I now means immune, because we have found out that is not something that we don't know is an immune problem. ITP is common in children, okay, the acute one typically lasts for less than 3 months, and normally is preceded by an upper respiratory tract infection, and most of them recover spontaneously, so they have a transient, less than 3 months problem with the excessive bleeding. So the clinical vignette is going to be very easy to recognize. Okay, 6-year-old kid or 10-year-old kid that had the flu or had a cold some time ago, and then started with bleeding, etc., etc. There is nothing else. Everything else is negative. No abnormal findings on the physical exam or nothing else abnormal. What is going to happen? They are going to get better. Well, do we have to do anything? Just wait. Now, there is a chronic, and it lasts for more than 3 months. And this one is more common in adults. Okay, and as we get older, we have more likelihood of developing this immune thrombocytopenic purpura. Okay, so right now, this is an autoimmune process that we still have to find the cause. Notice that now the name is not idiopathic, but the pathogenesis includes the name idiopathic because we don't know the ultimate cause of this. Okay, in the case of children, if they had the upper respiratory infection, we suspect that there is an autoimmune reaction against the virus, for example, and these antibodies got confused and started attacking our red blood cells. But in the case of adults, normally we don't find what is the triggering event. Okay, so what you are going to find is antibodies against the platelets. And when the platelets are surrounded by antibodies, these are the platelets that are traveling through the spleen. Okay, when something is surrounded by antibodies like this, the macrophages are going to trap it and are going to eat it. So we are going to have a lot of macrophage activity in the spleen, eating platelets, thinking they are bacteria. Okay, so this excessive activity in the spleen may lead to splenomegaly. Okay, so they are going to have, in some cases, not very common in kids, because they have it for a very short time. But in adults, that is a chronic process, they may develop a splenomegaly. Okay, so there is increased phagocytosis of the spleen, of the platelets in the spleen, and of course, we are going to detect the thrombocytopenia. So they have this platelet type bleeding, superficial, and they may have an increased number of megakaryocytes in the marrow and some immature platelets in the blood smear, which are larger than normal. And that is simply a compensatory attempt of the body. About thrombocytopenia, we also have to mention heparin-induced thrombocytopenia, which is, let me tell you, something that very commonly appears on the panels. Okay, every time our students finish their exam, I try to call them or meet with them if possible, or message them and ask them, do you remember any questions? Do you remember anything? And this is something that very commonly appears. As the name says, this is induced by heparin. Okay, it's self-defining. But there are two types. Okay, type 1, type 2. There is a type 1 is a mild self-limited condition. Okay, that will present 2 days after receiving heparin. And this occurs simply because of heparin-induced platelet aggregation. Okay, the same drug, heparin, makes the platelets to aggregate, so they are forming clusters. So the total number decreases, the ones that are available for blood clotting decreases. Platelet count will be between 100 and 150,000, of course, and has a good prognosis. 2 days. This is key. Now the type 2, which can be bad, presents between 5 to 15 days after heparin administration. When patients are receiving heparin, probably they were admitted because of something, a fracture, or something that makes them to be immobilized, or any other thing that we need to control the coagulation. So if this presents 2 days after the start of heparin, they are probably in hospital. They're probably still in the hospital. However, 2 weeks after or 10 days after, they may be at home. And not everybody has a family, or not everybody has a family that is able to think about what's going on here. Okay, is this a problem? Is this not a problem? Should I call? Shouldn't I? So this can be bad. And one of the reasons is people don't realize the severity of their problem sometimes. And in this case, it's not simply the aggregation of the platelets, normal aggregation induced by heparin, is that there is a binding of heparin to something that is called platelet factor 4. Now we have heparin binding to this molecule, a molecule to molecule, forming a complex that is called heparin PF4 complex. Okay, let's say this is a platelet. They have a protein that is called PF4, and heparin binds there, now forming a weird thing on top of the platelets, and this will activate the inflammatory cascade, leading to a release of different cytokines, inflammatory cytokines going as crazy in the blood, producing fever, chills, flushing of the skin, and of course the bleeding. Notice that in the type 1, there is no fever, there are no chills, flushing, nothing like that, simply low platelets. And the consequences, of course, the superficial bleeding. Now, after the release of these cytokines, we have more steps. Activation of the coagulation cascade, activation of other platelets, so it's an amplification leading to a hypercoagulable state. with formation of deep vein thrombosis, possibly pulmonary embolism, strokes, myocardial infarctions, ischemia because of the generalized thrombosis. Okay, this hypercoagulation will consume all the circulating platelets, so the platelet count will be very, very, very low. Okay, because of the consumption and also because the spleen is clearing all these platelets that have this complex on top of them. Notice that it says bleeding is not very common. And why could that be? Why, if they have such a problem, bleeding is not very common? Well, there are several explanations, and one of the most accepted explanations is exactly the one that also explains why bleeding is not very common in patients with cirrhosis. Why? If someone has liver cirrhosis, liver failure, and we know that the liver is the one that makes all the clotting factors, people with cirrhosis don't have excessive bleeding because the liver makes the coagulation factors, but also makes the anticoagulation factors, and also makes the fibrinolytic factors, make everything. So you have a decreased coagulation factors, but also decreased anticoagulation factors. So everything is like in the same level. Okay, here we are consuming the platelets. Okay, we are consuming the clotting factors, but also the anti-clotting factors. Okay, so it's a weird thing to understand. Okay, there are many hypotheses, many things that try to explain this, but this is what we find. Bleeding is not very common. Okay, so let's stop here and have a break, okay, and to analyze the other things. So I want to put them in a separate block. Please, any questions? Any questions that you might have now? Okay, perfect. Let's see each other in 10 minutes, okay? 10 out of 10. See you in a while. Okay, we are ready to continue. Let me start by sharing the screen. Okay, and we were talking about the thrombocytopenic disorders. We are going to enter into more detail. We are going to later understand how to make a differential diagnosis when we have a patient with bleeding disorders. And also, let's see if we can practice some questions. Okay, I think, yeah, we are going to have time. Okay, so let's go back to the classification here. I want to make sure you understand something. Remember, the patient, the bleeding patient, depending on different factors that we find, the history of the patient, the type of bleeding, and the results of the coagulation studies, is going to be classified into primary hemostasis defect, secondary hemostasis defect, and mixed disorders. Okay? Let's say we have a patient that is bleeding, and we are going to study in detail, or more in detail, the Bombiligram Factor deficiency. Okay, but also we are going to mention some other conditions that are very rare in the clinical practice, but may be common in the pants. That are conditions that we normally have to use to differentiate Bombiligram factor disease or Bombiligram factor deficiency, okay, from other types of disorders. Okay, Bombiligram factor deficiency typically presents as a platelet disorder, but may present as a mixed disorder, as we have it here. Okay, and we are going to try to understand why. This condition is common, okay, is common, and is the most common inherited bleeding disorder, okay, or maybe acquired, maybe an autoimmune condition. Okay, typically the inherited disorder is because of a genetic mutation that may either affect the quantity or the quality of Bombiligram factor. Okay, what is Bombiligram factor? Okay, we have here a diagram that shows what Bombiligram factor is. This is a protein that has different functions. Okay, the main function is to allow the binding of the platelets to the endothelium when there is a damage. Remember, the first step in the hemostasis, in the primary hemostasis, is the adherence of the platelets to the endothelium. Okay, so when there is a damage, endothelial cells will express this protein that we call the VWF, and that will serve to bind the platelets here. There is a receptor in the platelets that is called GP1B. That is the receptor that recognizes and has affinity for this Bombiligram factor. Okay? So, as we see here, we have some details about how the platelets form the platelet plug. Okay, damaging the endothelium leads to exposure of the Bombiligram factor. Platelets bind to Bombiligram factor using the GP1B receptor. Okay, now in the second step, that is called the platelet aggregation, is when this platelet binds here. Remember, it starts secreting serotonin, ADP, and other things that will attract other platelets that will bind to these platelets that are already there. Okay, but the union between these other platelets and the ones who initiated this process is going to be done by using another receptor that you see here, okay, that is called GP2B/3A. Okay, it serves to remember that the GP1 is in the first step, adherence, and the GP2 is in the second step, aggregation. And the union is done using fibrinogen. Okay, because from this diagram, we can understand the pathogenesis of several of the deficiencies that have to do with the platelet action and the process of formation of the platelet plug. For example, this protein may be deficient, and we call that Bombiligram Factor deficiency or disease. But maybe the Bombiligram Factor is okay, but the problem is that some patients don't have, or the platelets are defective and they don't express the GP1 protein. In that case, we call it Bernard-Soulier syndrome, BSS. Or they may have problems, okay, for example, in the aggregation of the platelets in this step, because they have a deficiency of the GP2 protein, GP2B. If that's the case, we call it Glanzmann thrombasthenia. Okay, so notice that von Willebrand disease and Bernard-Soulier syndrome both affect the adherence of the platelets, while Glanzmann thrombasthenia affects the aggregation of the proteins. Okay, and this also has implications for the therapy of the patients. Because, for example, sometimes the problem is, in the case of von Willebrand disease, okay, we may use a medication to induce the production of Bombiligram factor. Okay, if we create more Bombiligram factor, platelets are going to be able to adhere there, and that's the solution. But what if they have Bernard-Soulier syndrome? Doesn't matter how much Bombiligram factor is there. Platelets don't recognize Bombiligram factor. But there is another type of Bombiligram factor disease in which they produce Bombiligram factor, but it's defective. Let's say this is the normal shape of Bombiligram factor as it appears there. Maybe they produce an abnormal Bombiligram factor that has a different shape. So if we give a medication to induce the formation of Bombiligram factor, they are going to make it, but it's going to still be defective, or it's not going to work either. Okay, so it's a mutation that affects the quantity or the quality. So if the problem is the quantity, it is okay to give medication to increase the production. They're going to have more. But if the problem is the quality, we don't do anything by inducing the formation of more because it is bad quality. What about the inherited one? Well, in the inherited, there can be different conditions. For example, lupus. In lupus, they produce lots of antibodies, and they may produce autoantibodies against von Willebrand factor or in blood malignancies. So imagine that this is the endothelium, there is a damage, this is von Willebrand factor waiting for the platelets, but we make antibodies that bind there. How is a platelet going to bind there if there are antibodies in between? Okay, and if we give them Bombiligram factor or induce the formation is going to happen the same. It's going to be covered by antibodies, so that's not a solution there. Now, we have to understand another function of Bombiligram factor. That's not the only one. Okay, when we make the coagulation factors, okay, they are going to be circulating as zymogens, inactive. They circulate as inactive zymogens, and then they have to be activated by the cascade. Coagulation factors, as any other protein, have certain half-life, so they stay in circulation for more or less time. Okay, one of the coagulation factors that has the shortest half-life is factor 8. Okay, one of the functions of this Bombiligram factor, it allows the transport of factor 8 and protects factor 8 from degradation. Okay, so if these people don't make Bombiligram factor, factor 8 is gonna travel without protection and it's gonna be destroyed very early after the liver produces it or the endothelium produces it. Okay, so when people have any defect in the quantity or quality of this protein, they are going to have very low level of factor 8 in the blood. Okay, when we make coagulation tests, they are going to have elevated PTT, partial thromboplastin time. The PTT test normally assesses the intrinsic pathway, PTT, while the PT typically assesses the extrinsic pathway. So depending on how severe the condition is, Bombiligram factor disease may manifest as only a platelet disorder with simply bleeding more than usual, or as a mixed disorder with prolonged bleeding time and also elevated PTT. Okay, so in the case of a mild Bombiligram deficiency, the only thing they are going to have is increased nosebleeds or prolonged menses or heavy menses or epistaxis, different superficial bleedings, but a severe defect that manifests as a mixed disorder. They are also going to have elevated PTT, and they are going to have spontaneous hematomas and hemarthrosis. Remember, bleeding in the joints, hemarthrosis. And there you have a link. Okay, that's not something that we are going to ask you in the exams, but it's something that you need to know. And probably in clinical medicine, you're going to study it, and you have to be prepared for this when you do the PANS. But simply understand the type of deficiency. If it's a quantitative, by giving more or by inducing the formation, we are going to fix the solution. But if it's a qualitative problem, okay, we have to give it. Okay, we are not going to induce the formation. So what else? We have to understand, for example, what happens when people have vitamin K deficiency. Okay, vitamin K is necessary for the proper synthesis of different coagulation factors. For example, fibrinogen, factor 7, which belongs to the extrinsic pathway, factors 9 and 10. Factor 9 belongs to the intrinsic, and factors 2 and 10 belong to the common pathway. So vitamin K deficiency is going to affect everything. Okay. How people develop vitamin K deficiency? Low intake, low synthesis. For example, people taking long-term antibiotic therapy, people with deficiency in the absorption of the vitamins. There are some vitamins that are lipid soluble, ADEK. So someone with pancreatic insufficiency, someone with any malabsorptive disorder or biliary insufficiency will have a problem with absorbing vitamin K. Or people who are taking warfarin, which acts as a vitamin K antagonist. Since this affects the extrinsic, intrinsic pathway, and also the common pathway, everything is going to be altered. Okay, prolonged PTT that disrupts the intrinsic pathway. I placed 10 in the intrinsic here, but need to remember that 10 is like the end, okay, of the intrinsic. But the extrinsic, that has to do more with the 7, binding to tissue factor, also is going to activate 10. So from 10, okay, we can start counting the common pathway. Okay. Now, PT is going to be abnormal, prolonged, because of deficiencies in the extrinsic pathway. Okay, and factor 2, that is in the common pathway. Now, notice that note there. Simply affecting factor 2, this PT and PTT would be prolonged. Okay, doesn't matter how the other ones are. But typically we don't have a factor 2 deficiency. Okay, there are many slides at the end with some important information, okay, for interpreting the coagulation tests. But to go back to the things that we have studied now, we have mentioned at least when you have prolonged PT and PTT, that is likely to be a vitamin K antagonist like warfarin or vitamin K deficiency. Okay, when we have a prolonged PT, okay, we have to think in problems with extrinsic coagulation pathway. Okay, prolonged PTT may also PTT only. Okay, that has to do with Bombiligram Factor deficiency, an intrinsic problem, or hemophilia. Hemophilia can be due to factor 8 deficiency or due to factor 9 deficiency. Factor 8 deficiency is called classic hemophilia. Factor 9 is called Christmas disease. Now, talking about hemophilia, okay, notice that PTT is going to be prolonged and they're going to have normal PT. Okay, this is a defect that appears only in males because it's an X-linked recessive. Okay, and generally, or always, when we have an X-linked disorder, it's transmitted from the mother. Let's say these are the sex chromosomes of the mother, and these are the father. These are basic principles of of genetic inheritance. Let's say this woman has a mutation in this X chromosome. Okay, typically, if the woman is going to have a girl, okay, imagine that this girl inherits the mutated X gene. Okay, the other X is going to be okay because it's the one that comes from the father. She has the mutation there. Now, boys never inherit the X chromosome from the father. They get the Y from the father, and they may get this X or this X. If they get this one, they are going to be okay. But if they get the one with the mutation, mutated X, they are going to manifest the disease. Why women don't manifest the disease, even though they have the mutation? Because they have a good copy. That is okay. So they are going to use this chromosome to make the factor 8 or the factor 9 that they need. Okay, most cases of hemophilia are hemophilia type A, okay, 85% of the cases, and this is due to factor 8 deficiency. The other type, hemophilia B or Christmas disease, affects only 15% of the cases, and that has to do with deficiency of factor 9. Okay, prolonged PTT, these are, or these work in the intrinsic coagulation pathway. And the type of bleeding is, as we explained before, the clotting factor type bleeding, deep bleeding, intramuscular hematomas, okay, hemarthrosis, okay, GI hematuria, and severe cases may have a lot of joint damage, repeated bleeding inside the joints leading to erosions, leading to a loss of functions in the joints. Now we have to mention some hypercoagulation disorders. Okay, there are several. For example, one that is very common is one that we call factor V Leiden mutation. Okay, which is the most common inherited disorder. Okay, then we have other like deficiency of the protein CS or anti-thrombin deficiency that is here. And we have the anti-phospholipid syndrome. Okay, in the case of anti-phospholipid syndrome, there are autoantibodies, we call lupus anticoagulants. Okay, they are called anticoagulants, and this is something that we need to understand because in vitro, if you add these antibodies to blood, there is going to be increased coagulation. But in vivo, in the person, okay, so in vitro they produce anticoagulation, but in the person, they lead to hypercoagulation. Okay, to understand the hypercoagulability disorders, there are some concepts that are important to understand about how we produce the anticoagulation. Okay, we have to understand, for example, the function of factor 5 and 10, which are key in the clotting process. Okay, remember the coagulation cascade ends with the formation of fibrin to form the clot. Fibrin is going to be activated or activated by thrombin. Okay, and what activates thrombin? A complex made by factor 10 and factor 5. So this would be the last steps of the coagulation cascade. Now, when we form the clot, this fibrin has to be destroyed by fibrinolytic proteins. And the most important fibrinolytic protein is plasmin. Who activates plasminogen to form plasmin? there is a protein, an enzyme that is called TPA, stands for tissue plasminogen activator. Plasminogen activator that induces the formation of plasmin from plasminogen so we can destroy the clot. Lysis. Okay, now we need to understand what are protein C and S. Protein C and S will form a complex. They will bind. These are two proteins, but they need to bind to work together. Okay, these proteins normally, the function they have is to inhibit, C and S inhibit, block factor 10 and 5, so there is no more coagulation. At the same time that we initiate the coagulation cascade, we activate anticoagulation proteins, so the thrombus or the clot doesn't extend too much. Okay, so if we have, for example, deficiency of proteins either C or S, or deficiency problems with the any other of these proteins, there is going to be hypercoagulation. The thrombus or the clot is going to extend, forming a thrombosis. There is another protein that is called anti-thrombin. The name is self-defining. Remember thrombin? Anti-thrombin will inhibit this. That is the name anti-thrombin. Heparin inhibits factors 2, which is fibrinogen, inhibits factor 9, 10, 11, and 12. So inhibits many clotting proteins. So deficiency of anti-thrombin also leads to hypercoagulation. So these people are going to have predisposition to DVTs, to pulmonary embolism. Now, what is factor 5 laden? I have to, if I use another slide, let me erase the pen here. Okay, factor 5 laden. Remember we mentioned before that protein C and S inhibit factor 5. This is factor 5. Protein C and S form a complex, CS, and they have to be together, and they have to bind to factor 5 to inhibit it. If there is a mutation in factor 5, the receptor for the complex protein C and S is going to be absent or defective. So there is no binding. That is what we call factor 5 laden mutation. Okay, affects the binding site for protein C and S complex. So we don't inactivate this and continues promoting the coagulation cascade. And in the case of anti-phospholipid syndrome, remember in lupus we produce many antibodies. We mentioned before antibodies against Bombiligram Factor. Well, there could be also antibodies against anti-thrombin or antibodies against protein CS and TPA. So this may act through different mechanisms. Now, what about the disseminated intravascular coagulation? This is a great emergency that you don't want to be facing ever. Okay, there can be, for example, triggers like inflammatory cytokines, pancreatic enzymes, toxins from bacteria, generally gram-negative bacteria. Okay, cases of trauma that we have a lot of abnormal things in the circulation. For example, these crush injuries, some obstetrical complications like amniotic fluid. amniotic fluid in the blood. That is called amniotic fluid embolism. That is not very common. Cancers, pancreatitis, blood transfusions, and these abnormal substances in the circulation activate the coagulation cascade everywhere in the circulation. So we have a widespread formation of thrombi that consumes platelets, clotting factors to form many thrombi everywhere. So consumption of the platelets and the clotting factors leads to bleeding. Typically, they have bleeding from more than two or more sites. For example, hemoptysis and hematuria, or bleeding from the place where we have the intravenous catheters, oozing blood. Also, we have activated the fibrinolysis. Okay, so there is an increase in the degradation products of the fibrin. Once we break down the clot, fibrin is broken down to form fibrin degradation products that we know as D-dimer. That is the importance of this test. How are going to be the findings? They are going to have elevated bleeding time. They are going to have elevated or prolonged PTT, prolonged PT. They are going to have low platelets. They are going to have low fibrinogen. Okay, and they are going to have elevated D-dimer. Okay, this is what we use to differentiate the IC from the other things that we mentioned before, and other problems that may affect the coagulation. Okay, overdose of warfarin or heparin. This is simply showing you the different disorders that predispose to hypercoagulation. Okay, notice that factor 5 laden, okay, is the most common. In the general population. This depends on what studies you do, no? Anti-phospholipid antibodies are found in up to 7% of the general population, but that doesn't mean that they are going to produce a hypercoagulable state. Okay, factor 5 laden is the most common cause in Caucasians, at least. Because remember, lupus is more common in, can be common also in black people, etc. But in the Caucasian population, factor 5 laden is the most common. Okay, what is the percentage of people with factor 5 laden that have DVTs? 20% is the most common cause of DVTs. What about hyperhomocystinemia? Hyperhomocystinemia is a marker for many different risks. Okay, remember we talk about these people who with B12 folate deficiency, but many people may have a hyperhomocystinemia and not have B12 or folate deficiency. Okay, this is something that varies a lot in the general population, and there is a lot of debate about if we could use elevated homocysteine as a marker of different things. Okay, notice how different studies vary. What is the percentage in the general population? Some studies say 5, other studies say 10%. And the percentage of DVTs also varies depending on what is the prevalence in that population. Okay, and I think we have some time to cover some of the questions, okay? This is what we are going to have for Wednesday. because I needed to have this clear how these things are used in questions. Okay, here we have a 25-year-old female. Okay, notice that she presents with the right calf larger than the left. When you see that, that is a DVT until proven otherwise. Okay, she started oral contraceptive pills recently, denies any long-term train or plane rides. Okay, the Doppler examination reveals the DVT that we were suspecting, and she started on heparin, low molecular weight heparin. Now she reveals that she had 2 spontaneous miscarriages. Family history also shows several relatives with unprovoked DVT. And there you have several options to choose from. I'm gonna give you 30 seconds to think about the likely response. Notice, young lady, several miscarriages. Several miscarriages. And given this, this could be anything, okay? Given this could be anything. But when we don't have clear the diagnosis, okay, first of all, we are not gonna think that she has a malignancy. Okay, she's young, we don't have any reference, okay, about any of any malignancy that she may have. Okay, so we are gonna rule out malignancy. Hyperhomocystinemia, well, this occurs in people who have risks of cardiovascular disease or B12 folate deficiency. Nothing in the question makes us think about that. Then we have protein C deficiency. Then we have anti-thrombin deficiency, factor V laden, and anti-phospholipid syndrome. APS is typically present in people with lupus. So I don't think she has lupus. We don't have anything there. Could be. Maybe this is the first presentation of a lupus, but I don't have any clue to think about lupus. And also, I have here something that says family history. Oh, this is something that is inherited. Well, inherited could be protein C deficiency or S, but these two are very rare. I have the two most common, AT3 deficiency and factor V laden. Since I don't have any clue to distinguish between them, I will go with the most frequent, that is factor V laden mutation. Okay, that's how we answer questions. Now, let's go to another. We have the same options. Now we have a 30-year-old female for evaluation of recurrent fetal losses. Fetal. Okay. She reports having 3 past spontaneous abortions. Several spontaneous abortions, recurrent fetal losses, that is advanced pregnancy. And she has a history of deep vein thrombosis. She denies ever being diagnosed with systemic lupus, but has been diagnosed with thyroid disease. So we have here something different. Okay, notice that, or compare this with the previous, okay, with the previous one that simply mentioned miscarriage. And here we have something that is more heavy about spontaneous abortions, trees, and recurrent fetal losses. And she also has a thyroid disease that we can suspect this is autoimmune. Why? Because it's the most common cause of thyroid disease in the United States. Autoimmune thyroiditis or Graves' disease or Hashimoto thyroiditis. This associated with recurrent abortions, fetal losses, makes us suspect, okay, that she has Anti-Phospholipid Syndrome, in which we have antibodies against protein C or antithrombin 3 or protein C and S or TPA. See how we do the differential in equation? See how little detail is important to choose one or other option? What is heavier in this history? The autoimmune problem and the recurrency of the abortions. Again, we don't think she has a malignancy, and nothing makes us think about something that has to do with hyperhomocysteemia. Notice that they write in this question, and this is a question that I didn't create, it's something that I got from a PANS question bank. She denies ever being diagnosed with systemic lupus. That will take the students away from the correct answer, because we in our mind associate lupus with antiphospholipid syndrome, and that is a great and very heavy distractor that may guide us into choosing factor V laden mutation. Okay, but notice that the thyroid disease plus the importance that they give to the abortions, okay, is what makes us choose the antiphospholipid syndrome. Now what? Okay, we have here a 35-year-old Caucasian female with unilateral leg swelling. Do you notice that she's getting older? The previous was 25, then 30, now 35. She reports that she developed painful late-sided leg swelling and redness earlier in the day. Otherwise, she's healthy, takes no medications. She denies any travel, prolonged travel. She had a similar episode in the opposite leg 1 year ago, was diagnosed with a thrombus, deep vein thrombus, and they show an ultrasound, okay, that demonstrates the thrombus in the left popliteal vein. Genetic workup reveals that she has an inherited condition. What is the most likely mechanism here? I'm going to give you a little time to think about this. Inherited condition, first of all, what are inherited conditions here? Antithrombin deficiency, protein C deficiency. What is resistance to clotting factor degradation? That is another way to say factor V laden mutation. That is how they change the terminology to confuse the students. This is not inherited. This is not inherited. So we have to choose between these three. I told you first that this is very rare. So antithrombin deficiency or factor V laden, And as I told you, the most common among Caucasians is factor V latent, and that's the correct answer there. Okay, there is an explanation, okay, for you to read. I don't think you have this in your PowerPoint. Okay, I will upload this version so you have the correct answers to this. Then we have a guy, okay, we had 3 women, now we have a guy here, 61-year-old, history of lung cancer, was hospitalized due to shortness of breath. Okay, during the hospitalization, he developed a sepsis, was oozing from the IV catheter. I hope you are prolonged. There is thrombocytopenia, and the dimer is elevated. Well, we just talked about this a minute ago, so we don't have to stop too much. Notice that everything is bad. The dimer, PT and PTT, thrombocytopenia, and he's bleeding everywhere, past history of cancer and sepsis, so all the factors point towards the IC. That's an easy one. And then we have another here for interpretation of the coagulation, Cascades plus a peripheral blood smear. Before reading the question, take a look at these 2 blood smears. This on the left looks very nice, right? That's like a normal blood smear. Many nice, beautiful, homogeneous red blood cells. You have there a neutrophil. You have there a lymphocyte and some platelets. Okay, well, that's a platelet or 2. And this looks very bad. Very, very, very bad. I don't see too many red blood cells. There is an obvious anemia. I don't see any. I see a platelet there, but I don't see any white blood cell. Even some of the red blood cells have some weird things inside, and the shapes are not like these beautiful ones. There is a loss of the central, a decreased central pale area. Look like very round. And there is a broken red blood cell that is called schistocyte. Why is broken? Something's breaking the red blood cell somewhere. So we assume that the A is the bad one. I have 2 only with A. So if this guy has something wrong, I will choose A, 1 or 2. I think before reading the question. 61-year-old male with past medical history of lung cancer, hospitalized. Is the same guy before? Is septic, is oozing, so it's the same guy. That is that they use the same vignette. They simply change the options there. Okay, if this guy is so bad, of course, I will still choose the A. I don't think this guy with all that past history or all these problems will have a nice smear. So increase PTT and PT, decrease platelets and fibrinogen. Let's see the 2, increase PT and PTT, increase platelets and fibrinogen. I don't think so. If we are consuming the platelets and we are consuming the coagulation factors, platelets and fibrinogen should be very low. So I will stay with the 1. And of course, I don't expect a nice peripheral smear in this patient with that history. Okay, that's the correct. Okay, that's the end for today. That is the rationale. Okay, I'm gonna be uploading later this PowerPoint. And well, this is what we had for today, and Let's see if you have any questions. Okay, we are going to be discussing the malignancies, leukemia, lymphoma on Wednesday. Okay, please take a look before time so you have a clear idea before coming to the lecture. And I insist, please send me questions, send me emails. Okay, if there is something that is not very clear. I appreciate that a lot. Okay, so see you on Wednesday. Thank you so much for being here and sharing this time together. Thank you so much. Thank you.